My name is Kam Shojania. I'm a rheumatologist and head of the Division of Rheumatology here at UBC. I wish to thank the organizers of the BC Lupus Society Symposium, and I think it's great that we're doing it online in the time of COVID. I will be speaking about how to diagnose lupus, and I will really be talking about how physicians think. For the purpose of this talk, please place yourself in the role of the physician, not the patient. The important thing is that physicians will not always be accurate in making a diagnosis. It's not possible, especially with a diagnosis such as lupus or other conditions where there are different aspects to making the diagnosis. And you'll see as we go through the talk. I do not have any disclosures or conflicts related to this talk. I'm doing one study. I have some salaries from the UBC and the Ministry of Health. I do not accept money from any drug companies, and I do not speak for pharmaceutical industries. So let's just jump right in. The first case is Nadine. So you're in the position of the physician. She is a 34-year-old woman. She has had Raynaud's, which is a change in color of the fingers, white in the cold and red. She has joint pain in the wrists and fingers with swelling. She has a rash on her face. She is losing hair, and blood tests show a very low white count and low lymphocyte count. Her anti-nuclear antibody, going forward, we're just going to call it ANA. Her ANA is high. She has low levels of something called complement in her blood. She has some kidney involvement. She was fine other than Raynaud's up to a year ago. She's read about lupus. She's desperately hoping she doesn't have it. And when she comes into the office, her husband is also there for support. Here are some pictures. The rash is fixed. You can see it here on the face. It doesn't come and go. It's not a flush in the sun. It's just a fixed, slightly tender rash on the face. This is Raynaud's. The fingers changing color, white, red, and purple. You could see in the top left, sometimes it can involve certain fingers and miss others. So that's quite common in Raynaud's. So this is the patient that you're seeing. Is this lupus? Well, it's kind of staring you in the face, and that's how lupus is. It's not that subtle a diagnosis for the most part. So this was, yes, it is lupus. And we're not going to talk about treatments in this talk very much, but suffice to say, we started hydroxychloroquine. You gave her prednisone at a moderate dose. The kidney physician saw her, did a kidney biopsy that confirmed lupus in the kidney, but it was early. She was treated with continued prednisone, mycophenolate mofetil, sometimes we call it MMF, and continued hydroxychloroquine. She met with the nurse. Her lifestyle was reviewed. Pregnancy was discussed, and not now, but in the future when she's off prednisone. Vaccinations were discussed, sun protection, osteoporosis prevention, and generally lifestyle maintenance and healthy lifestyle choices were discussed. And she did very well. Okay, we're going to come back to Nadine. The next case is Wendy. Wendy is a 45-year-old woman who comes in with arthritis, facial rash, Raynaud's, hair loss, and a high-level ANA. She has been fatigued for 20 years. She's on disability already for chronic fatigue syndrome. She's depressed, lots of life issues happening. Her GP did a screening test and found her ANA was high, so she was referred with a diagnosis of lupus. Of course, it took about 4 months to get in, so in the meantime, she read about lupus. She understands she's got the diagnosis because of the ANA. As an aside, her insurance company is cutting off her disability, which she was on already for chronic fatigue syndrome. All right, you're the physician. This is a difficult situation. And here's what we see. We see she has some arthritis, the top right. We see a facial rash in the bottom left. And we see some hair loss over the top of her head. So in medicine, we sometimes lump things together. So a medical student looking at this will say, well, arthritis, hair loss, facial rash, ANA, must be lupus. But that's not always the right thing and the right diagnosis. So if I was asking some students about this case, they would look at this very closely and go, you know what, that arthritis looks like osteoarthritis. Because it's got Heberden's nodes at the tips of the fingers, Bouchard's nodes in the middle of the fingers, the base of the thumb is involved. So that doesn't look like lupus arthritis. It looks like osteoarthritis. A dermatologist will look at that facial rash and see some papules and the fact that it involves a nasolabial fold. The look of that rash doesn't look like a lupus rash. It looks like rosacea. That hair loss over the crown of the head looks like it could be a certain type of alopecia, pattern alopecia, maybe telogen effluvium, which is another type of hair loss. So we're looking at these three features, and is it lupus? No. Is it one condition, or is it several conditions? It's most likely several conditions. However, Wendy was expecting a lupus diagnosis. Not that anyone wants to have lupus, but it sort of helped explain why she had the rash, the arthritis, the hair loss, the blood test, the fatigue. It's a good reason that she's not going to get cut off disability. So she was not happy about the lack of a diagnosis. Though we tried to explain these things, she wasn't really having it. And probably Wendy is going to go get another opinion. All right, let's come back to Wendy as well. So now we've done two cases. Third case, Jasmine. So this is a 30-year-old woman with a 2-year history of persistent skin rash on her face after a trip to Mexico. While she has joint pain in the wrists and ankles, it doesn't last more than a few weeks at a time. It improves with activity. She's had a viral infection, maybe from one of her kids, and she was admitted to hospital with inflammation around the heart or pericarditis for 4 days. When you examine her, you notice a ruddy complexion. The rest of the exam was normal. The ANA, also highly positive. Her lymphocytes, the subset of white counts, were borderline low, and she had low complement C3. And that's a picture of the rash. Sort of like not thickened. Interesting. It's sort of ruddy complexion there. Is it lupus? Well, you're not sure. You know, there's some features, some not really. This is real life. So you think maybe. And you have 3 choices here. We'll come back to those choices. But you do additional tests to check her blood counts, kidney function, liver function. You test immune system activation. Nothing's found other than her ANA, the low lymphocytes, but the C3 repeated is now normal. She's happy that the tests were good, but she's puzzled and says, so what's wrong with me? Do I have lupus or do I not have lupus? So how do you respond? You could say, number 1, yes, you have lupus, but it's mild. You start hydroxychloroquine. You don't need the stronger medications. You teach about the disease. You make some lifestyle changes, sun protection. She should quit smoking. It's a whole other talk on smoking and lupus and rheumatic diseases. Or you could say, 2, no, it's not lupus. Don't worry about it. This was probably post-viral pericarditis. That rash is probably not lupus. It's all good. Go live your life, but still quit smoking. Or 3, maybe it's lupus. And you'll see her in follow-up every 3 months, maybe for a year, because it will declare itself if it's lupus. Talk about healthy lifestyle choices. So what do you do? If this was in person, I would pick people out of the audience to ask them to respond. So think about it. What would you do? Yes, no, or maybe. You're the doctor. Well, you decided to diagnose it. Number 1, you start hydroxychloroquine. You don't give her prednisone. She quits smoking. She protects herself from the sun. No more big trips to Mexico. She was ambivalent about having kids anyway, but now that she's got a diagnosis of lupus, she decides not to. She stops running outside, and she's a bit more focused on her health. She decides not to take a new job in the United States due to concerns about getting health insurance. Also, now that you've made a diagnosis of lupus, she can't get disability or life insurance. Okay, that's case 3. 15 years later, you're still her doctor. She's pretty satisfied with her health and her lupus. She's actually had no lupus flares. She's been taking hydroxychloroquine and getting her eyes tested yearly. Her rheumatologist is retiring. She sees another rheumatologist, some young, cocky rheumatologist who reviews the initial diagnosis and the 15 years of no lupus symptoms and questions the original diagnosis. Did she have lupus initially? If yes, maybe it's gone into remission. She's worried about stopping the hydroxychloroquine in case she flares. Okay, so we're going to go to the last case. So we've done 3 cases. 4th is Klaus. This is a 65-year-old man with malaise and fatigue who develops a skin rash, joint pain, and pleurisy. Takes no medications and otherwise is healthy. Blood tests show he's a bit anemic. His white count is normal. Kidney and liver function is normal. Cleared for cancer and infections, which can be associated with some of these symptoms. But his ANA was found to be elevated. This is his rash on his arm. Chest x-ray. Oh, he's got a pericardial effusion. Is it lupus? And you think probably not. You know, it's not common in men. It's not common in older guys, you think. Doesn't have typical features. You said watch and wait. There's not enough fluid around the lungs or the heart to drain. So let's leave him alone and see what happens. 3 months later, you get called to the CCU, the coronary care unit. He was admitted with fluid around the heart. It was affecting the heart pumping activity, so it's kind of dangerous at that point. It was drained and no infection or cancer was found. But a skin biopsy was done during that admission and it showed classic lupus features, though the kidney and other organs were fine. So in fact, he does have a diagnosis of lupus. We call it elderly onset lupus. That's a whole other discussion about how lupus affects people who are older. Anyway, he was started on hydroxychloroquine, given some prednisone. You felt a bit sheepish because you missed it, but he forgives you. He forgives you and he still sees you as a patient. So let's look at this grid. At the top is what's true. True lupus or not lupus. On the left side is what you diagnosed. You diagnosed lupus or you did not. So the first case, that was pretty easy. Nadine, she had pretty classic lupus. You treated it. She did well. Life is good. She was tapered off the prednisone and the other medication. She remains on hydroxychloroquine. The other job you did well was Wendy. You did not diagnose lupus and she did not have it. She was the one that had the osteoarthritis. She had the rosacea and she had the telogen effluvium in the scalp. Okay, you did those just fine. Where you didn't do so well is Jasmine. Actually, she didn't have lupus. She was the one that stayed on hydroxychloroquine for 15 years. You diagnosed it, but you were wrong. She actually never had it in the first place. What are the consequences? The other person that you kind of messed up was Klaus, the old guy. He actually had lupus. You missed it. What were the consequences? And this is the sort of thing that doctors deal with all the time. You know, are you right? Are you wrong? What are the consequences of missing the diagnosis or overdiagnosing? So my question to my colleagues or the students are you an overcaller or undercaller? Are you more likely to commit to a diagnosis in a clinical situation compared to your colleagues? Or are you under a caller? Are you less likely to commit to a diagnosis compared to another physician? Or perhaps you make both types of mistakes. Or I sometimes ask them, do you make neither of these mistakes? Which worries me if someone says, I never do either of those things. Let's go back. What happens in the long term? All right, we've got this grid again. Nadine, Jasmine, Klaus, and Wendy. Well, Nadine, again, you did well. Damage was prevented. Good outcomes. Organs are all good. She's on very little medication. Okay? Wendy, you did the right thing. Medications were avoided. The real issues were addressed, which were osteoarthritis, rosacea. She has another fatigue issue, which is not related to this diagnosis. And where you kind of didn't do well is Jasmine. And what were the consequences? Well, a couple of decades of medications not needed. And she, remember, made some life choices that maybe she didn't need to make. She stopped going to Mexico. She stopped running in the sun. She decided not to have children. She decided not to take that job in the United States. She wasn't able to get insurance. And how about Klaus? You missed the diagnosis with Klaus. And he ended up in the CCU, had to have a needle draining that fluid. Could have been bad. It wasn't, but it could have been bad. But there was a 3-month delay in that diagnosis because you made a mistake. What was the most difficult case out of these? I can tell you the most difficult case was, for me, Wendy. Out of all of them, she was the least happy of this, of not having a diagnosis of lupus. That doctor never helped me at all, she could say. Klaus was also a tough one because you missed it. You apologized. Jasmine wasn't that hard. You missed the diagnosis, but it really didn't come back to hit you until you retired, and the next person said, hey, I don't think she ever had it. Let's go back to the anti-nuclear antibody. What is that test? Is it useful? When should doctors check it? It kind of was central to each of these cases, wasn't it? Should it be repeated? Is it always abnormal? Well, I can tell you that every one of us has anti-nuclear antibodies. It's kind of a cleanup antibody that we all have at low levels, and some of us have it at a higher level. Most people with lupus have very high levels of anti-nuclear antibodies, or ANAs. They're a diverse collection of antibodies directed at normal molecules, components of the cell nucleus. They're associated with connective tissue diseases like lupus, Sjogren's, scleroderma, polymyositis, and dermatomyositis, but also with certain cancers, drug reactions, autoimmune thyroid disease, liver disease, and even regular people who have nothing. Sometimes you can do further tests looking at extractable nuclear antibodies, and they can be helpful if the anti-nuclear antibody is positive. It can sometimes direct you into a diagnosis. Often not, and often it can be misleading. Here's the thing. The ANA is positive in 98% of people with lupus. 98%. But it's also positive in 40 to 70% of other autoimmune diseases. It's positive in 5% of healthy adults. It's likely higher as we get older. Here are the extractable nuclear antigens. They're Smith, Rho, La, RNP, Jo, double-stranded DNA, antihistone antibodies, anticentromere antibodies. They can be ordered, and things like the Smith SM point a little bit more to lupus. RNP can sometimes point to another condition. Anti-Jo can sometimes point to a subtype of dermatomyositis. But you know what? They're not always that helpful. So, going back to my questions, what is an ANA? Is it a useful test? Sometimes, but there are pitfalls. If I randomly pick up someone off the street and do that test and it's high, it probably doesn't mean anything because that person doesn't have symptoms of lupus, and the chance of that being significant is very, very low. When should doctors check this test? When you suspect an autoimmune systemic disease like lupus, Sjogren's, myositis, or scleroderma. It should not be used as a screening test. Does it need to be repeated? Generally, no. So the problem is with the majority of the tests when people order ANAs out there for screening, they're not helpful, and if positive, point us in the wrong direction. So how do you know if you have definite lupus? Well, if you have biopsy-proven lupus or organ dysfunction, or maybe a skin biopsy that shows cutaneous lupus, or objective clinical features that can be confirmed, that's a diagnosis. I think it's important to know that lupus eventually does declare itself. It's not too vague the whole time. It can go into complete remission, so there's lots of people out there on medication and lupus is not active anymore. It's great. It can grumble along, or it can have caused damage and then gone into remission, and what you see as lupus activity might be previous skin or kidney or other joint damage that is not really active and requiring treatment. How about when should you rethink the diagnosis? Well, as a specialist, I think regular assessment, reconsider, think a little broadly. What if? Well, what if it isn't lupus? What else could it be? Sometimes we diagnose lupus and in fact the patient has something else like Sjogren's. That eventually sorts itself out, or dermatomyositis. That eventually sorts itself out in the proper diagnosis, and the treatments are very similar anyway. I think a good quote is, lupus can do everything, but not everything is lupus. So even if you have lupus and then you come in with a fever, chances are it's not lupus, it might be an infection. Or you could have another condition in addition to lupus. So not everything you get when you have lupus is related to lupus. I think it's important to remember that fatigue, joint pain, hair loss, and rash are all common conditions. And the majority of people with fatigue, joint pain, hair loss, rash don't have lupus. Is it okay to ask for a second opinion in difficult cases? It's not very expensive. Maybe it's $200. Second opinion is about the same cost as a bunch of blood tests and much cheaper than an MRI. The opinion is probably worth more. And it will put your mind at ease if the second opinion confirms the first opinion, puts the doctor's mind at ease. So if a patient asks me, often embarrassed, say, well, should I have a second opinion? I always say yes. This is my shameless plug of talking about lifestyle measures for all of these cases, that exercise is a type of medicine. It really helps almost all aspects of rheumatic disease. However, you have to remember there are 4 types of exercise: strength, stretching, a range of movement; cardio, getting your heart up; and balance, agility. So simply walking, if someone says, I walk for exercise, I'm like, that's great, but it's not enough. You need to do some of these other things. And there's some ways to get all of these into your exercise program or activity regimen. Well, I'm going to stop there, and I know that we will be having a Q&A session live as part of the BC Lupus Society Symposium. I look forward to talking with you and answering questions.